Oh, you're welcome.
RFA and who is a candidate for it, and can it help my low back pain? So we'll delve into this. Prior to doing so, I want to just kind of introduce myself a little bit and some of my background. So I started, kind of my undergraduate education, University of Georgia, initially from Roswell, Georgia. Completed my medical school training at the Philadelphia College of Osteopathic Medicine. I then went on to complete my residency training in physical medicine and rehabilitation at the University of Kentucky. And then I went on to do a advanced fellowship in interventional spine and sports medicine, from a non-operative standpoint. It's got a lot of good exposure up there during my fellowship training, and then turned back on down south to head down a little bit closer to the mountains and rivers and beautiful area here in Eastern Tennessee. So very excited to be here talking to you guys today about radiofrequency ablation. And so in deciding kind of the way that we were going to go with this talk, we decided to just kind of model this after common questions that are asked. So first and foremost, what is radiofrequency ablation? How does it work? Where in the body is this procedure commonly used? Who is a candidate for the procedure? What happens during the procedure itself? What kind of things can I expect if we decide that, you're a good candidate for moving forward with this? What happens on that procedure day? And then what are some of the risks, potential side effects that you can either expect or hopefully not expect after the procedure? And so with that, we'll kind of delve into that first question, what is radiofrequency ablation? And so in order to understand, some of the background behind some of this technology, we just need to think about, radio waves, and somewhere in the spectrum of frequencies here are radio waves that you can kind of see right here. And so when we talk about radio frequency, we're talking about this radio frequency current, which is then converted into energy as heat. And we use that heat to create focal targeted lesions. And so that heat can be applied to nerves like we commonly use in interventional pain procedures or in other areas of medicine. So I put this slide in here really just kind of talk about, the general setup. And so all this starts with a radio frequency generator, which we see here. And you've got two wires that kind of come out of this thing. One goes to a grounding pad, which is placed on the body. And the other wire goes in through this kind of insulated cannula that comes down. Now, the tip of that wire, which is ultimately connected to this machine, does come out. And this tip is where that energy is, that focal kind of radio frequency current is transmitted. And so in this other picture, you see those waves. What they do is they start oscillating and flipping molecules back and forth. And so when those molecules flip back and forth, that releases heat as kind of energy, and we get that kind of focal tissue destruction that we're looking for. So just in summary, we've got alternating current, generate heat, and that heat is focal targeted destruction is what we're ultimately getting here in the end. And so this procedure is used in multiple areas of medicine, which is, I think, kind of the next thing that we're going to kind of go into. And the idea is the same. So the same idea from the previous slide is the same kind of all throughout these procedures. So if we look on the left side of the screen here, there's other areas of medicine this is involved in. It's just, like I said, focal tissue destruction is what we're looking for. So tumor ablation, ablating vessels that go to tumors, ablating kind of aberrant signals that go through the heart. So if you get a cardiac arrhythmia, Cardiologists use kind of the same technology to ablate those currents. Fibroids and then varicose veins, just using that heat to kind of close up some of those veins. Now, over here on this other side, this is really kind of what we're going to focus in on today, which is, how you use this to address, pain. And there's multiple areas that you can, target. People were commonly, neck pain, back pain, thoracic pain from potentially rib fractures. And there's multiple areas of chronic joint pain which can be addressed with radiofrequency ablation. Whether that be shoulder, hip, knee, SI joint. There's focal neuropathies. After the nerve kind of leaves the back and the spinal cord region, it travels down, and there can be areas where it can be compressed. And so you can end up with a focal neuropathy or neuralgia from compression of this nerve. And so, when people talk about radiofrequency ablation, there's multiple names that are kind of thrown out there. I put this in here because, it can be confusing. And if you hear any of these things like thermocoagulation, neurotomy, lesioning, they all kind of mean the same. We're getting some sort of ablation, lesion, neurotomy, just targeted damage to the nerve that's being done from heat. And anyway, if you hear any of these names, they all mean the same thing. So I wanted to focus in on one particular joint or region of the body, which is commonly addressed. I know in practice here for myself, which was low back pain. And in particular, low back pain that's coming from degenerative disc disease and ultimately from these joints in the low back. So you can see here, what we've got is facet joints. So these are the little vertebral bodies. Between each of them is a disc. And you can see between these two, we have degeneration in this disc. And so what happens over time is, we start get a degeneration in that disc. We start kind of putting extra load onto some of those facet joints in the back, and then we get accelerated degenerative changes. And so these joints are just like any other joints in our body. They can be prone to arthritis and just general wear and tear. And they do have, all the similar, structures as well. They have a joint capsule. Within that joint, there is joint fluid. And on either end of the bone there is a cartilage. And over time, all of that starts to degenerate. You get inflammation, and then you get pain, focal pain, which is derived from some of the inflammatory factors and processes going on. So additional things to kind of note here is, in general, these facet joints do help provide stability to the spine. They help us move. Over time, they can become arthritic and degenerate. In people with chronic pain, in general, we see a prevalence of, about 45% of people, up to 45% of people have pain coming from these facet joints. And currently, there's no real good feasible way to replace these joints like you could with a larger joint such as the knee or hip. So we talked about, some of the degeneration and inflammation within that joint. And so, the next part of the discussion, that we're leading into here with, treatment for this is, how is some of that pain transmitted and perceived? And we process all of our pain through our brain. And so all of these signals end up getting transmitted.
I can't hear you, Dr. McGuirk. Uh-oh. Hold on. Let me bring you my computer. Huh. Yeah. Sorry, everyone. Hey.
Can you not hear me?
No, I can't hear you.
At all?
Mm-mm. Hold on one second. Can anyone hear us? Judy, can you hear us?
Unmute them.
Okay, yes, they can hear us. Okay, sorry.
Oh, okay.
Yeah. I'm gonna leave this in here for you to talk on, and you can do the slides with that.
Okay.
Is that okay?
Did we hear anything to this point?
I heard you were talking about the nerves. Go back a slide. Okay, start there. And I'll leave this up and you can see questions, but you can look at your PowerPoint there. Is that okay?
Yeah, this is
you'll
fine.
have to share the screen from there. Sorry, everyone. I'm gonna pull it up on my
Are you
phone.
sure we can't hear from here?
Can't hear on there for some reason. I don't know what happened. It just like all of a sudden went out on you.
It's weird. Okay.
Oh, sorry.
All right. Sounds good. Thanks, guys. All right, everybody. So I guess technical difficulties. You can hear me now. Is that right? Okay, awesome. All right, so I'm gonna kind of look at two screens here and we'll make this work. Okay, so on this slide, I'm not sure where audio cut out, but I was trying to draw an example here of a potential target site that we can use from an interventional pain standpoint to address okay, sorry. So this is a potential target site here for general pain that we can use and target everything with radiofrequency ablation. So with this here, I think I wanted to highlight in general that like with any joint in the body, you can get degeneration over time. And we start to see that. You can see in this particular example, we look at these kind of vertebral bodies, then you've got, the disc here, another vertebral body. And so the disc between these two has started to degenerate. With that, you end up having increased load and forces here, which ultimately accelerate arthritis and degeneration here. And that can manifest as inflammatory changes. And the inflammatory changes in general are what we perceive to be pain. Particularly with movement, which only kind of worsens things. Like any other type of joint here. Can you guys still hear me? I think I just saw a mute button.
No, I can hear you, Dr. McGuirk. I muted your computer in case it all of a sudden came back on. So sorry, I didn't mean to confuse you.
Okay, all right. Okay, so in general, I wanted to bring up these facet joints because they are prone to arthritis. There's not a great fix from a surgical standpoint. You can't just replace these joints. And in general, pain coming from these joints is fairly prevalent. So I brought up this here to talk about, how the brain perceives pain to actually be happening at these joints. And so if we look at, say, this joint, for example, we can see that there are small little kind of nerve growths that come out to this joint, and they provide innervation to the joint capsule. And so inflammation within that joint is ultimately going to be transmitted through these little small nerves that travel back and head their way back to the spinal cord and go up to the brain to actually be perceived as pain. And all of that pain signaling process, the interpretation of that in the brain has to happen. It has to happen through the connections of our nerves. So with each facet joint, there is two small nerves, these medial branches, which do provide innervation to that joint. They do provide that sensory pain signaling. So these are our potential targets here that we have in interventional pain to go after, either from trying to numb those and block those signals, or try to use our topic today, radiofrequency ablation, to ablate those nerves. And so how do we diagnose, facet pain? Oftentimes, this can be a difficult diagnosis to make. Your traditional history exam, there may be, certain things that you say in there that point us towards thinking that this could be, just focal area within the back coming from these joints. The exam, there are certain maneuvers that we use to try to lead us one way or another. And then ultimately imaging, which will probably show some degenerative changes. Studies do show that imaging does not necessarily correlate with your pain level. So, overall, if we're looking at this here, this is a CT of the back. So we look at, both of these joints, and you can see this one here, you got, space here within the joint. You don't see as much degenerative changes as you do on this other side where you have kind of this large bony outgrowth over here. The inside of the joint is a little bit collapsed. The edges are a little bit irregular. So you would, probably perceive most of the pain would be coming from, this side more so than this side, but that may not necessarily be true. So, there are multiple ways that we can address the pain and potentially work towards moving forward with a radiofrequency ablation. Depending on multiple reasons, we may decide to pursue one over the other. But just kind of generally speaking here, we could consider facet joint injections. This is a direct introduction of a needle into the joint, and we place steroid into that joint to decrease some of that inflammation. So, generally these are more therapeutic than they are diagnostic, but they can be diagnostic in the sense that if we do this injection and you get pain relief, then, presumably that pain's coming from that joint. The duration of relief from these does vary. Generally, 4 to 5 months is, I think, what a lot of us tell patients to expect. This here is just kind of an example of what we're doing. So we are taking a needle here and we are introducing it directly into the joint. And then within that joint, we're putting steroid and anesthetic to hopefully relieve your pain. So this is an outpatient procedure. It's done under a fluoroscope or an X-ray guidance. And you can see here in this picture, there's the small kind of sliver. This is the joint space that we are targeting here. And so we intermittently take pictures as this needle gets a little bit closer, and we try to introduce that needle into that joint. So in this particular patient, this was done at 2 joints, this one here and this one here. You can see that kind of black streak here is dye that we have put and introduced into that joint to make sure that when we later inject the steroid, it is truly within that joint. So next thing to talk about, we had mentioned some of those small sensory fibers that carry all of that information back to the brain. So that's truly what's the signaling process by which all of this happens. And if we can block this, we could potentially block your perception of that pain. So this is traditionally a diagnostic procedure, meaning that the effects are temporary. What we're trying to do here is we're trying to very specifically block a certain medial branches, and we're trying to get you, some pain relief. If we got, only partial relief, we may need to include, another joint or two. But they can be very helpful for, helping us to figure out which joints in particular are causing most of your pain. Generally speaking, what we're looking for here is anywhere from 50 to 80% pain relief. Just kind of depends on your definition. Now with this too, we also kind of want to get some of that feedback and hear what you're able to do that you weren't previously, potentially because of these blocks. We would consider that, a successful block if you had, 80% pain relief, if you're able to do more than you were previously. Now, importantly, some insurance companies do require for us to do 2 of these and for both of them to be successful before we move forward with a radiofrequency ablation or more permanently introducing heat to damage that nerve, not just blocking with anesthetic. So these are just pictures of the medial branches. Here again is similar to the previous diagram. We have these medial branches. These are carrying sensory input back into these nerves, which are then going to kind of move up to the higher centers where it's processed as pain. So if we look at this joint here, we can see that we've got, part of this branch coming up and going, and then part of this one down here coming up. And so to block this joint, we would need to block the medial branch here and here. And so you can see these are just pictures of where we would localize those needles to with the X-ray machine. And finally, just kind of getting into what we came here to talk about today, which is this radiofrequency ablation. Ultimately, you're probably going to go through one of those other procedures prior to moving forward with this. So I really wanted to kind of talk about those because that's ultimately how we get down to here. So a little bit about, radiofrequency ablations. They are a therapeutic procedure. We do use this to get longer lasting pain relief. With the procedure itself, it's done just like the others, where we bring you into kind of an outpatient procedure suite with an X-ray machine. Depending on how you did with some of the medial branch blocks, we might consider light sedation. The procedure does tend to be a little bit longer than those other 2. And so just depending on our, how well you may tolerate it, we may consider a little bit of light sedation. Alternatively, these procedures can be done at, ambulatory surgical centers. But that would be, just kind of a discussion that you would have in clinic. Like I mentioned, we're using the X-ray machine to place these cannulas, just like needles, just slightly thicker. They're insulated. We again put them down to that medial branch. We then test prior to turning on the radiofrequency current and the heat. And we do that to make sure that, we're not getting any sort of motor response. Sometimes these needles can, pick up there close to where the actual nerve root is coming out. And we want to make sure that we're not getting motor activation. So you may feel some slight twitching in your back, but we would be more or less looking for twitching in your leg at this point. Assuming that we don't get any motor response and we don't need to reposition any needles, we would move forward with the lesion. So we would turn the machines on. And they would heat up and you would stay heated for about 90 seconds. At that point, we'd probably reposition the needle and create another lesion to make sure that we've gotten the nerve entirely. The whole point of this procedure is to use that heat to denature the nerve, to more permanently kind of sever that connection of sensory input, pain input. And overall, things to expect, this procedure in general takes about 30 minutes or so. So this is kind of optimal positioning and placement of the cannulas. You can see that they are going to a similar position as they were with the branch blocks. These are slightly thicker, what looks like needles, cannulas here, and they're going down into very similar positions, which is what I wanted to show you there. So here's an example of what the radio frequency generator looks like on the right, and how it's ultimately hooked into these wires that are then kind of put in through these cannulas. So on the left side of the screen here, we want to make sure that everything's right on top of where that nerve is. Once we've made sure, we take this little stylet and we pull that out. And then through that opening, we insert the end of the wire here, which is connected to that radio frequency generator. We would then, turn this on, and the temperature would increase there, ultimately ablating that nerve. So results, what can you expect with this? So, we do these diagnostic procedures to make sure that the RFA is going to be successful. And because of that, studies show very, high success rates with this, upwards of, 70 to 90%, depending on the study. But in general, we're expecting you to have, a good outcome if you've gotten through the steps prior to this. Pain relief does typically last up to, about 12 to 14 months, can go up to about 2 years, but in practice, generally we're seeing about, a year and a couple months of relief. Noticeably, that is longer than you're probably going to get with steroids. And then, some of the downstream consequences of that improvement in pain, being able to just tolerate your activities better, being able to range your back a little bit better, decreasing some of your pain medications there. And then potential side effects that we probably just need to talk about, just so you can know what to expect, would be, a couple days to maybe even a week of pain, which is worse than you came in with. That can be, fairly common. This does tend to improve around 2 weeks or so. And by about that 6-week mark, we would expect to see start of, gradual improvement in your pain getting much better. Other, common side effects or things to maybe expect would be, muscle spasms, soreness at the area where the needles went through, potential bruising at that site, and then skin numbness over where those needles are is somewhat more rare. And sometimes you can get these sunburn-like sensations overlying the skin. Those are rare, but harmless and tend to go away over the course of about a month or two. And then, down here, very rare, but something, we probably talk to everybody about in clinic, which is the very rare and off chance that you do end up with, nerve damage just because of where these needles are placed. Because we are moving through the skin, we're tracking a needle down, there is a risk of infection. We do everything under sterile conditions to greatly reduce this risk. And then finally, one of the last things is that your pain can return. So these nerves do tend to regrow. And if that regrowth equals a connection in that kind of circuitry, we can always go back and repeat this procedure. Studies do show that you tend to get as good results, if not sometimes better and longer lasting than the previous ablation with repeat procedure. So finally, who is a candidate for radiofrequency ablation? I think we talked about, some of the process by which, you're going to go through probably, conservative treatments, probably have failed some of those, including, therapies, modalities, oral medications. We're probably going to have tried either some FACET joint injections with steroid, or perhaps, we're trying, something else like, blocks of these nerves. And in general, we're looking for a positive response to those blocks to indicate that your pain is truly coming from, the joints or the nerve or, the source of pain has positively been identified. You could also be someone who has issues where you've done really well with steroids, but all of a sudden that effect from the steroid is gradually fading, and they're becoming, you feel like you've got the need to have those injections more frequently just to get relief. And then finally, there are, certain scenarios around joint pain where, you may not want to go forward with the surgery. You may want to explore, ablating the nerves that innervate that joint capsule. Or maybe you're just not a good surgical candidate because of comorbidities, and you've got heart issues and diabetes, and it may be riskier to move forward with the procedure, like a joint replacement, and we may open the discussion on trying to ablate some of these nerves. And then finally, if you're someone who's had surgery, continues to have pain, there's multiple different avenues which we probably need to explore. One of those treatment options could include, radiofrequency ablation. So in summary here, hopefully, we've touched on how does the procedure work, who's a candidate, and we've come out with these kind of key points here, which are that there's a wide variety of uses for radiofrequency ablation. It's very commonly used for back pain. The method in which it works is it takes that current, it creates heat, and it's focal heat that creates focal nerve destruction. In general, nerve blocks and positive nerve blocks predict good success. And because of that, you do have a high success rate with the procedure. Generally speaking, it's well tolerated. There's low complication rates, and you do get longer lasting relief. And finally, most important, just getting you back to enjoying life, doing the things you enjoy doing, which is the most important, I think, to me and everyone else in the practice. All right, so I guess at this point, I'll open it up to questions that you guys may have. Be happy to answer those.
Sorry. Get them.
I think so.
Let me pull it up here just in case anybody sends it. Okay. Okay, everyone. While everyone's typing their questions in on the chat box, I'm just going to go ahead and kind of wrap us up and kind of let you guys know the follow-up that we'll have. So this whole presentation has been recorded. We'll cut out the part where we couldn't hear everybody. So sorry about that again. But if you will, just put your questions in the chat box, or if you have a long one, you can ask to be unmuted in the chat box, and I'll unmute you. Let's see. Sorry, I see some private messages. Okay, sorry about that. But like I said, I'll send this out to everybody that signed up, and it will be on our Facebook as well. But if you want to schedule an appointment with Dr. McGuirk, you can do so by calling us at 865-690-4861, or you can visit us at TOCDOCS.talkdocs.com, or you can send an email to the RSVP email or the feedback email. But again, I will put all of this in a follow-up email to all of you. Let me see. For some reason. Okay. Does anyone have any questions before we get off? I know it's kind of hard to think on the spot, but if you have any that come up later, you are welcome to send an email as well to the RSVP email. And I'll get those to Dr. McGuirk and get you the response back. So give it just a few more minutes. Oh, here you go, Dr. McGuirk. If you'll just read it out loud so everybody can hear.
Okay, so we have a question out there. Questions is, I had the RFA procedure and did not think it helped. I had given up going to the doctor with pain because it didn't help. Should I come back? Yeah, so this is, I think, a good question. And part of this, I think, would include trying to figure out, did you respond well to the medial branch blocks? Did you move from, facet joint injections with steroid to the radiofrequency ablation? Every now and then,